Welcome to person-centred care planning. Has anybody actually had this before or seen a webinar or anything around it? We're all familiar, some familiar, all others new. Who's been in general practice for less than 2 years? Okay, and who's been in general practice for more than 2 years? Excellent, so we've got a good mix. And who is doing care plans in their role? So the majority, yep, great. So part of the presentation success is the interaction from the actual audience. If you have a question, ask it. In a room this size, there will be 20 other people that will have that same question. So we're all in a safe environment, be courageous. As you've just seen, there are experienced nurses in the audience, and getting their knowledge and tapping into their wisdom will be good, because I'm not the only one in Australia that knows this stuff, yep? And hopefully by the end you'll be a lot more confident yourself. So let's get going. What we're going to look at is the funding. Of course, we always want to know the money. We're going to look at the eligibility. We're going to develop a person-centred approach. We're actually going to look at what that is. What does it mean and why is that different to others? And we're going to look at how we can improve the communication. So practice funding, the very first thing around, practice funding, I'm going to lose my voice, is the PNIP. And I want that to be the first thing in your mind whenever you are thinking about money in general practice. As general practice nurses, we generate for 12.6 hours of work a week for a registered nurse, the practice receives $25,000 per annum. Do we all know that? It's often hidden from us, and it's hidden from the discussions in the practice. But that's a significant contributor. It's up to five equivalents, so what we call, it's worked on what they call a swappy, which is just the way Medicare work it out, and they will not release their actual logarithm to you, so you can check their workings out. But there's also rural and AMS loadings. So indeed, a practice can receive $125,000 annually if they have 5 RNs working 12.6 hours a week. And 1,000 swappy is the equivalent of 1 full-time GP. So the first thing that we have to consider as general practice nurses is that we are giving a significant contribution to the practice just by turning up. Well and truly before we even look at billing care plans. And the other overall practice fundings, of course, are the PIP payments around the diabetes and around cervical screening, yep? So they're another form of practice funding. The interesting thing that we all need to know here is that the PIP is under redesign. And that is happening. It's already been happening for 12 months, and it will probably be concreted within the next few years. And what will happen there is the majority of the PIPs will be all rolled into one. And then that will become a quality-based PIP. And that will depend on the practice data. So the PNIP is not going to go, and nor is the mental health nurse funding. It's just changed its structure as we speak. But always remember, you're bringing in individually $25,000. Don't ever let it get put over you. So for a care plan, it's worth $258. I don't use the cents and stuff like that. I just round it all out. A review of a care plan is a GP, MP and a TCA. A care plan is not one or the other, yep? That is the combination of the two. And to review a care plan, therefore, you are reviewing the GP, MP and the TCA. So you're doing 2 reviews. So you bill 2 732s. So that means it's $144. You can also have a contribution to a residential aged care facility, and that's a 731 only is the residential aged care facility, and that's around about $70, the equivalent of a 36 billing item. Contribution to another doctor's care plan is possible. Very difficult to try and work out where and when to do that. And also don't forget that once you bill a 721 and a 23, or one or the other, so even if a person only has a team care arrangement, we now have 5 10997s. So they're 5 practice nurse follow-up education. And indeed, you get those as well for billing a 731 in the residential aged care. So I know where I've worked in a practice at home, what we used to do was go in and contribute to the care plan, and the GP would follow along at some stage for their appointment for it to be signed off. But then what we used to do was go to the nursing home and do the ear syringing using our 97s rather than bringing a demented patient out for a very confusing assessment into an environment that they're unfamiliar with. So there's lots that you can do with these 97s. Do we all bill the 97s? We all... Yeah. It's one of the very least billed items, and it, depending on the practice size, it can be $50,000 revenue in a practice that's got around 5 full-time equivalent GPs. So it's another significant contributor. So there's also in our chronic disease management the GP time-based only. So it doesn't matter what you do, your time cannot be included. And that's the asthma cycle of care, the diabetes cycles of care, and the mental health care plans. Because remember, mental illness is a chronic illness. And we know in Australia that this disadvantaged group, those with mental illness, that their physical care is lacking. And also the treatment that we provide for people with mental illness actually increases their risk of death. So this is where we need to pick up our game for this disadvantaged group. But no matter what it is that you do here, your time cannot be included. It is only the GP time, and that's very important that we understand that. We won't look at those guidelines. We will. Do we have the internet? We'll see if we can actually access and have a look at a few of the sites that are very helpful. So the eligibility, we all know this, don't we? Chronic illness of greater than 6 months or is terminal. So you don't have to be terminal for 6 months before we can help you with a care plan. Yeah? We've got that. And you don't have to have had that illness for 6 months either, whatever the illness is. You have to know that it is going to be chronic. Does that kind of sit comfortably with people? Or are you generally waiting for 6 months? At diagnosis. Don't have to wait 6 months at diagnosis. Absolutely. Yep. So the chronic illness or terminal. But in 2010, that's why I don't like microphones. In 2010, there was a bit of a discrepancy amongst clinical guidelines and Medicare. And Medicare kind of said, well, crap, we're not clinicians, so we can't tell a doctor what to do. And if we're constraining general practice in implementing the best practice clinical guidelines, then shit, we can be sued. Yeah? So they opened it up. And that was 7 years ago, and we are still stuck on this chronic illness thing. There are so many people in the community that are missing out. So the clinical decision on the GP can be based on things like reduced capacity to self-care. Have a think about that. How many people have you seen with reduced capacity to self-care? Intellectual or physical disabilities, including kids. Sorry? Cool, thanks. In some instances, if there's obesity and high blood pressure or impaired fasting glucose, or, we've got hypercholesterolemia or our liver functions, we're heading into a fatty liver, those people can have a care plan. In some instances, it's not everybody, and the rule we use in our practice is they have to have 2 of them, and that they will benefit from a team care arrangement, and that we know that they will actually adhere and work with the care plan as well, so that we're not just riding them for the sake of it and bringing money in, yeah? So there's a lot of different things. There's also this one around hospital discharge, but let me tell you, I've never, ever, ever been able to work that one out at all, yeah? Never. Because what's really, 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 really important is that it's not me telling you what's okay to do, it's you locating the information that enables your practice to, and sharing that with the GPs that you work with, yep? You don't go back and say, I met this woman and she said this, this, this and this. You find the evidence and you open it up and you talk about it in your practice like we have in ours, and come up with the plan of how you're going to implement that. So the requirements are the usual GP. We're all happy about that one, yep? Sometimes if we need a review and the GP's on holidays, another one in the practice can do the review. We need to document the consent. Who in their notes here documents consent? Individually, the nurse. We've got 1 or 2, 3, 4 hands. Are we autonomous health practitioners? Huh? We are. By our registration, we are. Do not be constrained by the ideas of general practice. You are a professional nurse. You are autonomous. So if you're working with a patient, you have to gain informed consent and document that. That is your role. And it's easy to do that. You just develop an autofill or a shortcut if you're in medical director that comes up and prompts you with what you're going to talk to the patient about to get to informed consent. But it is your professional responsibility. It must be a written plan, and it must be person-agreed goals. How many care plans have you seen where it's got improved blood glucose, improved exercise, improved nutrition, improve this, improve that, improve this, improve that? Any of that person-centred? No, that's a template that's been just loaded up and nothing's been done and it's just been handed out. There's no engagement whatsoever. So it's not going to make a difference, and it's not actually meeting Medicare requirements either. And you must collaborate with other providers. How do we collaborate, people in the room? How do you collaborate with your team care arrangement? The facts. Anyone else? Mail? How many people do the phone call thing and get to talk to the allied health person personally? For every person that's on the TCA, I think it's a mind-boggling attempt to try and do the phone call thing and talk to the physio, then talk to the podiatrist, the dietitian, the CDE, the optometrist, for every patient. And I'm holding all those that do that, yeah? Because the Medicare, that's what they want us to do, the phone call. But they don't mind if we do it by fax, or email. There's lots of different ways, but you must have some evidence of how you've collaborated. And that allied health has agreed to be a part of this team care arrangement. That's the requirements. We'll wait until we can get to those web pages. Cool. You want to come and help? Great. So review and renew periods. Does everybody routinely review their care plans? So this is the page that you need to go to and read. See all these fact sheets? This is everything that is actually going to tell you all of the stuff about the clinical decision, the reduced capacity to self-care, the potential of someone with obesity, the potential of hyperlipidemia getting a care plan. This is all here. So what you have to do is go to the Department of Health website and type in CDM Q&A. And then you'll get two options will come up, and you go for this one that was updated on the 14th of March 2014. And you'll get all of these fact sheets. And you can see it goes on for a while. See all the rules? And it's interesting, isn't it, that this is hidden over on the Department of Health website. There is a link on the MBS online, but it takes you a long time to find it, yeah? So indeed, with some of the other pages, what we could see, but it'll take too much time going through each of them, but what we could see was that you have to go to the MBS online and type in 721 and read it. And you think, yeah, that's okay. But then there's also going to be another link that says explanatory notes. And the explanatory notes is the A3 link. It's going to give you a lot more information. And at the bottom of your A3 link is the link to take you over here to the Department of Health website. If you haven't been through all of those three sections, then you don't know what you're doing under Medicare's requirements, yeah? And often in general practice, our GPs depend on us as the nurses to find all of these rules for them. Yep. So that's a big step that we can do for our patients and our practice. So it's interesting, isn't it? Because it can be at 3 months. It can be at 3 months if there is a clinical need, which was exactly what you were saying over here. And our clinical guidelines tell us to review them at 3 months. But a person with diabetes that has had it forever and a day and they've been managing it very effectively with their nutrition and their HbA1c is 6.3, well, they don't need it reviewed every 3 months, even if the clinical guidelines tell us to do it. The important thing is, if you are reviewing it less than 6 months, you must document the reason in your notes. Otherwise, if there's an audit and there's no documented reason as to why, then they consider it an invalid review. So it comes back to what you write in your notes again. 12 to 24 months for a care plan. If you're reviewing 3 monthly, are you doing renews at 12 months? Yeah. Being proactive, yeah? As long as the clinical notes tell us why that need is there. And so that's a part of my autofill. Review period set for whatever month due to. That's a part of what I actually write there and discuss. Exceptional circumstances, anybody familiar? Anybody understand or know what they are?
Circumstances have changed, such as you've been having somebody with diabetes seeing you and then they develop cancer and we suddenly change it because it's within that 1 month after they've had their management plan.
So that's clearly what exceptional circumstances is, where you can bill a new care plan or a review within 3 months before that time period is up. And the clarity comes under that A3 link that I told you about. It's very clear. And it says there is a significant change in the patient's condition or treatment plan. Significant change. So if they've got a new diagnosis and it's not going to change anything on the plan, you don't need a new care plan. But if you've got a whole range of medications and a whole lot of new education and you need a whole different group of team care providers, then that is exceptional circumstances. So there are some times when that can be used as well. So remember, that's your explanatory notes. And we've been hearing about the healthcare home, so we thought we just need to put a slide in. Our PHN last week actually had a whole day. They had some really, really good speakers around this, because I'll have to say, for me, I thought, let's just look. So this is the old presentation, just to let you know. So some of the bits on it are not quite. So I did this before I went to that day. And yes, they're going to segregate patients into 3 levels: high-level care, medium and low-level care, yeah? And there's going to be different pay scales, block funding for that. Care coordination is actually going to be a large part of the package. And rather than the potential to reduce the funding, it's actually going to reduce funding and role, it's actually going to improve the potential role for nurses. So please don't take this slide home with you. You need to turn it around, yeah? So we're not going to know until we get there, but the potential is that nurses will be coordinating care, and that it won't be based, the funding will not be based on GP face-to-face time. So all the time that we spend on the phone, and we might go home and visit the patient and all of that will be a part of the package, yeah? So let's forget that one. And this is going to mean that we're missing a few other slides. This is the beautiful Illawarra. This is the escarpment. It's about 45 minutes up the road from me. And I just love this photo with the light shining through, focusing on the person. Yep, and here we go. Person-centred care, yeah, it is the old one. We're back to front and everything. Person-centred care is about engaging with the individual, so that you can tailor the education that will empower the person with the knowledge and enable them to make informed decisions around their health care. So it's very different to the way we have been working. It is all about empowering and enabling, but to succeed at that, you actually have to engage it first. Yeah, it doesn't have our model in it. This is going to be a hard bit. So this is on your table. And this is the person-centred model that I use. And you can see on the outside, it talks about the prerequisites of the member, of the health professional. And then we have the actual environment. And this is why this would be a really good model for the healthcare home, because it talks about what changes we need in the environment that we work as well. And the centre is about the person-centred care. And you can see, and it's the centre circles that were on the slide, you can see that what it's about is actually engaging with a person so that we can encourage shared decision-making. We can improve health literacy. We can look at them as a person and care for them holistically. And we can actually work with their values and beliefs. Who feels in general practice that they connect with the values and beliefs of their patients? Don't lie now. It's a very hard one. So what are some of the values that you've uncovered with your patients? Those that put your hand up. Sorry? Yeah. So the value is that that's what the person is after. Yeah. And that's what they're expressing to you. Yeah. That their roles, did you say? Their goals. Yeah, that's a really good one, isn't it? We all into therapeutic relationships? It's a buzzword. It's going to start coming out a lot bigger and stuff, but they're really important, the therapeutic relationship, because it's all about our boundaries as well, our professional boundaries and the encouragement of the person and including them in the decision making. But I want you to go and have a look at this, and this is McCormack and McCants. This is about their third model, and they're working on it even more. But really what it tells us that if we do this, then we're going to actually get satisfaction with care and involvement with care, and we'll get improved outcomes. But if we're not working, if we don't know what the person's core values and beliefs are, how can we connect with them and educate them? How can we advise them on what to do if we don't even know that that's something that's a part of them? We might be saying, take your medications, and their core value might be based on not having medications. And so they'll just sit there and nod and walk out the door and not take them. Yep. So it's hard, it's not easy work, and it's very time consuming to work with the person's values and beliefs. Care planning is always, as in anything in general practice, it is a collaborative team approach, and we need to have a dedicated meeting to get this sorted out, yeah? We need everybody to be on the same page. We need to look at our database and work out who are the people that we really need to prioritise and see. Who are the people that are not getting their care plans, as opposed to who are the ones that we're doing them for. Look in the database and find those that could have and haven't have, and engage them in care. We need to agree on the roles of the nurse and the GP, yep? No sense in me saying, I'm going to do all of this stuff when the GP wants to do it themselves, yep? But I'm sure, as you've found, that if we get out there and we do a really good job and we show the evidence, all of a sudden the GPs are saying, send them to Ros, send them to Ros, send them to the nurse, send them to the nurse. And that is a part of our job, is to strut our stuff. Nurses have built their careers on care planning. I know in my hospital training we had to do them. Nurses in universities are still basing their learning on care planning. We know this stuff inside out, we're good at it. And if we can demonstrate how valuable we are in this purpose and help patients, then, you know, we can go a lot further with it. So please go forward and do your best. But we also need to, identify the people that may not, that might be the do not arrives. You know, if that's something, if they always say, yes, I'll come in for a care plan and never turn up, then stop ringing them in that way. It's wasting all of our time, yeah? And, you know, who has an hour appointment? Yeah? How many patients are actually seen, you know, in combination with the nurse and the GP for an hour? You know, if you went back 10 years, it was everybody in the room was spending an hour. 5 years it was 50%, and now it's less than 10%. How can you do quality person-centred care in less than an hour? And it is combined GP time. I have an hour appointment and the GP's got to get their butt into my room and sign off, yeah? Because this is quality care. And bringing the GP into your room is such a valuable opportunity for us to learn from their wisdom. And, you know, it brings in this whole teamwork. And you as the nurse can focus this consultation and ask some questions, and the patient feels really special. I don't have to go and sit in the waiting room. I've already been here for ages. All I've got to do is walk out the door now. So are they more likely to come back for their review? Absolutely, because they're like, I remember, I go into that room and I leave that room and I go out the door, and the doctor comes in and we all talk together. It's quality care. If we're not giving the person an hour, then, you know, what's the value of the $258 except to raise revenue? The purpose of care planning is to improve patient outcomes, not revenue raise. And unfortunately, it started in that, and now it's turned around in a different way. And it's the patients that are missing out. And if you're not getting an hour, you are not working with the person's beliefs and values because you've got no time. All you've got time for is to do some obs and print some paperwork. Yep. How do you get to person-agreed goals if you haven't got the time to talk about it? Yeah? We're going to have a look what I do in the hour, and I'll be really keen to hear back from you about what you think. No, yeah. No, but it's a really good point. When you do know somebody a bit more, indeed the reviews I can get done pretty quickly once I know a patient. But currently I work with the very complex people and their combined mental and physical illnesses. So you've got no chance, absolutely no chance. I think that's the key. It's having that additional time get you to uncover and really get to know them. Because we had a woman that had been coming forever and a day. She's on warfarin, so she's at least once a month for an INR. And she'd had care plans and all that kind of stuff, and she landed in a consult room with me, and we're chatting and we're talking, and I asked her about her alcohol intake, and she broke down and cried, and she said, I'm an alcoholic. I can't stand my husband, and I get drunk every evening so I don't have to listen to him. I can just sit there. She'd been coming to the practice for years, but nobody had actually encouraged her and given her a safe place or given her a care factor that she felt safe to disclose that. And that was the key to everything, the absolute key. So it's interesting, but we have to set the scene. And again, I've got here about the hour appointment. We need to arrange for no interruptions. And the receptionists know where I work. Do not ring me unless I need to get up out of my chair and do CPR. You hold back and wait. Do not ring. This is that person's appointment, not anybody else's. So do not ring. And indeed they ring and I don't answer the phone. And if it rings back again, well then I know that something is up. But I'll just take the phone off the hook. Sometimes it's the boss, and it's like, I don't care. The patient is the boss, yep? So you need to have those kind of conversations with the staff, though. Give them fair warning and stuff. I do bring lots and lots of M&Ms for the reception staff. You know, we work really effectively together because we have these conversations, we know where we stand. But we've got to get our head in the right place. This is about active listening here. It's not about me going to tell them what it is we're going to do. I'm going to sit there and listen to them so that we can work out a plan, because that's how I uncover their values and beliefs, what their needs are, and discover what influences them. It's about my body language and their body language. Ask how often do you do your BGLs and they shuffle a bit? And I've got to make sure that I don't shuffle a bit and get the scour on my face. And they say, oh, probably not as much as I should. They haven't done them for 2 years. That's what the answer is. Or they say, oh, it's 6 to 8. Well, everybody knows 6 to 8 is acceptable. If they're doing it, it would be 5.6 to 7.3 or something. A person that's doing them will be very proud, yeah? So we have to look at these little clues to help us go further. But if we're so focused on what we've got to tell them, we're missing all of this. Because we have to ask open-ended questions until the time starts clicking, the clock starts ticking, and we've got to move on. Then you've got to close questions down. But by that time, the person feels heard. They don't feel that they have to keep rabbiting on, yeah? And you have to include them in the decisions. How do you feel about this? Can you please tell me what you understand about what it is that we've talked about today? What is the key take-home message that you're going with? All of those things are important. So before the person comes into the room, you really have to go through this whole file, yeah? First thing I do is go straight to the billing, because you never know if a GP snuck a review or a care plan in last week when they came for a script, and you're about to embark on something that you're not going to be able to bill for, yeah? So it's up to us to double check and make sure we can do what we're actually looking at doing today. You need to look at the medications and review the pathology. It's not until I do this that I know the illnesses that I'm working with, and then I can update the past history, because the past history is often atrocious and doesn't guide you very much at all. And then I have, as I said, my autofills that I use. I set the reason for visit straight away, and that's care plan. And anybody else got one that they use? Yeah? What do you use? So is this the reason for visit? Yep. So that's one of the coded ones, isn't it? Although care plan preparation to me is if I'm doing it without the patient. So I use care plan straight up when I'm doing the care plan itself. No other one? Yeah, you could use that. You don't have to put all the diagnoses or anything. What is a key role of a nurse? What's one of the jobs that we do for people? Everyone we see. Huh? Yeah. A nurse anywhere. When we talk with a person, what are we doing? It was one of the E words, of the 4 E words. Educate. As nurses, we are patient educators, and it is a coded reason for visit, patient education. And if you're doing a care plan and you want to demonstrate your value, please use patient education, yeah? And at any time when a 10997 is being billed, please use patient education. It's going to be highly supportive for when you're trying to push forward about the role of the nurse, for you to be able to say, look at this. And I used it recently. In a 1 month period, 89% of patients had patient education. excuse me, what that means is that we're improving the health literacy of 89% of patients, yeah? So have a look at what the actual reasons for visits are, because if it's not coded, you can't use the database to find it and tally it. So you can't free text them. But you need to have a look at what they are and everybody agree on what to do, yep? And you really, I always update my reminders and then load up my template straight away. And I fill out any bits and pieces that I can. But then it's about going through the correspondence in. Who is it that they're seeing? The correspondence out. Who is it that they're supposed to have seen? Look at all the radiology, look at all of that. That can take 10 minutes of the appointment, which means I'm now down to 50 minutes in my hour. So in the beginning, the BMI, the scales are between my door and the chair. So if they're going to avoid them, they're going to have to trip over them, and I can assess their balance anyway, yep? So it's a win-win. But people moan and groan, and they're like, oh, not that. And, you know, you don't even have to look at the number, it's fine. What question do we ask here? An engaging way of approaching weight. Sorry? Are you happy with your weight? Other ideas? Geez, you're looking a bit porky, mate. Have you put weight on recently? Yeah? Your trousers are hanging off your hips. You been eating lately? Like, what is it? Because weight is massive. It is such an emotional attachment. Such an emotional attachment. So I get them on the scales, and before they start, you know, babbling and getting uptight, I ask, is your weight stable? And the body language changes immediately. Because it's not saying, are you fat, are you skinny, are you anything? Is your weight stable? And they're 160 kilos, and they say, yeah, I've been here for 3 years. And I say, that's great. You're not going up and down all over the place. So what has just happened in that interaction? Was it engaging? They've opened their mind, and they're actually going to talk to me about their weight. They're going to tell me about their beliefs and values around it, yeah? And then I sit them down and, you know, do the blood pressure. And I'm sure you all know that in general practice, especially if you've got electronic devices, the blood pressure is generally elevated. The second time you do it, still a bit, and it's the third that is the closest to the real blood pressure. So I measure it 3 times. Turn the screen away from them, because if they're watching the numbers, their blood pressure will go up, yeah? So you just turn it away and keep chatting away. We need to look at the pulse, and we need to feel the pulse. Who feels the pulse? Yay! Why do we need to feel the pulse? There's a lot of AF, undiagnosed AF out there, and you might just catch it intermittently as well. Does everybody do pulse oximeter? Yeah. Blood glucose? Yeah. Not everyone. A lot of undiagnosed diabetes. Yeah. So it's a good one to do as a baseline, unless you've got recent pathology. Informed consent. This is where I do my informed consent while we're getting all of this stuff done, so the person can relax into their position, yeah? And then I go through their medication list, their family history and their pathology with them, and show them where the red spots are, and ask them about their tablets and why is it that they're taking them, and how come they haven't had a script for that for 12 months if they say they're taking it, yeah? And it's all health literacy, and it's all engagement, and it's all the opportunity for the person to tell you what they're thinking and feeling. And then we're now over at the template. The first question here is, what is your main health concern? Not the doctor says your health concern is diabetes. What is your main health concern? More than 50% of people answer with a social problem. The finances, the grandson that's on drugs, the granddaughter who's got cancer, the neighbours that are pesky, the council that don't pick the bin up enough. You know, all these kind of things. But to ask this question means that we are connecting. We're actually telling the person that we value your input. Yeah? It's you that this is about, not us telling you. It's about you telling us. Yeah? How long have you had your illnesses? And we assess now what their knowledge level is. Because we need to know here, don't we? Do we need some specialist nurses in here to help this person with their health literacy, yeah? Like the CDEs or the COPD nurse or the heart failure nurse, all that kind of stuff, yeah? Nutrition. And these questions I ask everybody. I'm busily typing away in these boxes this whole time, yeah? Is your diet healthy? What do you have for breakfast, lunch and dinner? How many serves of fruit and veg are you having a day? What kind of meats are you eating and fish? What dairy do you have? Low fat, high fat, full cream? Do you have margarine or butter? What kind of bread is it that you're eating and how many serves? How much water are you having? Do you add salt to your cooking? Do you add it at the table? Are you getting cramps at night time and you're not having any salt? And if we tell them to put salt on their evening meal and the cramps will go away, they're going to be very grateful. And how many processed foods, takeaways and snacks? This is the biggest area, this one. This takes a long time. Because if you're not assessing this against what our guidelines are for nutrition in Australia, how do you know? How do you know that they might need a dietitian? How are you going to engage them in a dietitian if you haven't been through this and able to explain what it's all about, yeah? What about activity? Who says how much exercise do you do? Disengaging. The word exercise is disengaging. You know, we learnt this through the Happiness Institute. When they changed it from exercise to activity, people actually felt more comfortable and they felt that they could do something. Whereas if we said, well, you do 30 minutes of exercise, they're like, no. Will you do 30 minutes of activity? Yeah. What activity do you want me to do? And what about an older person who can't do exercise? We say, how much exercise do you do? And they can't. Their activity is the gardening and the washing and the housework, yeah? But if we say how much exercise, they say, I can't do that anymore. I'm really sorry. I'm so bad, aren't I? The doctor always tells me to exercise. But we need to pump them up with the activity. Wouldn't it be good to say to people, look, you know, when the ads come on telly, why don't you stand up and do 5 laps around the house or around the coffee table? Yeah? Is that a start? It's fabulous and we can build on it, yeah? So all those little steps at a time. How active is your lifestyle? And they'll tell you a whole wealth of information. What kind of activities do you enjoy? What are the barriers? Do you do any specific exercise? And are you stable on your feet? Because reality is if we can get people out into the sunshine like this, then there's going to be a lot of improvement in their health, yep? A lot. But it's one small step at a time. In mental health and well-being, this can be a really big part as well. But what is your daily routine? If somebody's getting out of bed at 11 or 12 in the morning and saying, oh, there's no reason for me to get up, well, there's a high likelihood that depression's happening here, yep? Are you ever sad or alone? If they are all the time, then, yeah, maybe we've got depression. Do you have worries or concerns? Yeah, everybody does. But do they keep you awake at night? Well, then we might have anxiety here. What are the sleep patterns? Are they under financial distress? And please ask, do you use any substances? And they go, what do you mean? So what is a substance? So drugs and alcohol. Who said that? Who said that? Oh, it's so good, isn't it? That, you know, that we think that it's all only illegal stuff, yeah? And if you say, what illicit drugs do you use, the person will not answer because you've just turned it into a legal complex when we're here for health. So I ask, smoking, alcohol, any other substances? And you can see in the body language, but the majority are going to be fairly honest. Some need prompting. Cannabis? Yeah, I do. I have a joint at night time so I can sleep. And that's a key indicator. What is it that's preventing them from sleep? Because cannabis takes away dreams and nightmares. And so we need to uncover the reason that they're using it for that. Or is it that they're using it for pain relief? You know, are they dabbling in methamphetamines because they're depressed, or they've got ADD, or they're lonely and they don't know what else to do, or they're being manipulated? Are they into cocaine? Have they ever used any of this in their childhood? And it's almost 100% of people have tried something. So you have to broach these questions and talk to people to understand where they're at and what's influencing. And of course, if you're going to go into the question of mental health, you must ask about self-harm and suicidality. And it's a hard one. It was for me at first, a very hard one, until one man said yes. And I thought, holy crap, what am I going to do now? How can you say yes, you're thinking of killing yourself? I don't know what to do. You're not supposed to answer that. Like, you know, it's just one of those questions, you know. And it was, oh, God, now I've got to ask about a plan. Do you have a plan? And he's like, yeah, I'm going to hang myself. And it's, oh, please, somebody ring the phone and save me, you know. And then it's like, well, the next question is, do you have the means? And he said, yes, the rope is actually prepared and hanging in the garage. My wife and kids have gone off to Canberra this morning and I've come in to see the doctor to say goodbye. And that was the truth. And so that was one life that one question saved. We got the family back around, we got the mental health team, we got him through it, we saw him regularly, and you know, he's not even on antidepressants or anything anymore. But by being brave enough to ask that question, that saved that man's life and his family. Yep. So as health professionals, it's our responsibility. 49% of the general population will experience a mental illness somewhere in their lifetime. So we need to uncover that 49%. Medications. All the time I hear people say, are they compliant? Is compliant engaging? It is so disengaging. And I'm just going to say it here and now as well. So is the word diabetic. So is the word schizophrenic. They are all judgmental stigma. And as health professionals, it is our responsibility to reduce stigma around chronic illnesses. So it is a person with diabetes, a person with schizophrenia. It is a person before an illness, yeah? Change your language. You'll see a change in your patients and start trying to change the language of everybody else around you, yeah? It is a person with an illness. That's person-centred care. So in the person-centred care model, we're after concurrence. Do they know what it is they're taking, why it is they're taking it, what effect it has on their body, what are the potential side effects, what to do if they forget one, yeah? And are they actually taking it? And when you go through this routine with people, you'll often find they might be on 2 blood pressure medications. They're taking them both in the morning. Doesn't make sense, does it? You know, or they've been put on all, you know, the new fancy diabetes medications and they're taking them all in the morning. Or they stop their metformin because they're pooping through the eye of a needle and nobody talked to them about that and what to do if it occurs. Yeah? So we need to look at it from a different point of view. Not are you taking what the doctor told you to, but how do you feel about this? Why is it important, and do you understand it? Yeah, really important. Are they experiencing side effects? Are they taking any complementary therapies, including vitamin D? A lot of people on calcium as well, and the calcium can be totally unnecessary as well as dangerous, but they're taking it. People that are on antidepressants and taking St John's wort, yeah? And if you don't specifically ask the question so that they understand, they won't tell you. Do they have a regular pharmacist? That's such an important part of the process, that they have a regular pharmacist. Our practice has a pharmacy in-house. So often I'm in the pharmacist with that patient as well. We're in there together talking with the pharmacist, yeah? Going over some questions and ideas. And is there a need for a HMR? Vaccination. Who knows Halo? Who's a vaccination nurse? Let's have a guess. We're talking about H4 health. We're talking about vaccination here. So think about it. So it's health, age, lifestyle, occupation. Yay! Every person that's sitting in front of you in general practice is a potential vaccination encounter, and you need to halo every single one of them, yeah? Because remember, at 65 you can get a flu and a pneumonia vaccination. Who else is pneumonia vaccination recommended for? Is it recommended for asthmatics? For people with asthma? It's only if it's severe asthma with frequent hospitalisations. COPD. What age is COPD frequently diagnosed? Is it a magic 65? It's before it, isn't it? Yes. I love that health assessment. It's my favourite. But the reality, and the way I remember it, is crapped. Yeah? So it's cardiac, renal, alcoholism, pulmonary and diabetes. Pneumonia, Pneumovax is recommended in each of those categories of people in the minimum, well before they're 65. Pulmonary, and the last one is diabetes. So crapped is, you know, I mean, I know it's a bit naughty, but that worked for me in my head, you know, yeah? And of course, homeless people. You know, there's lots and lots of lots. In the kids, did they get their additional vaccines at 12 months and when they were 4, if they should have? Because they've been missed a lot as well. We're good at influenza. Well, actually we're not. Yeah, we are exhausted, aren't we? But apparently only about 48% of those that can get free vaccination do actually get it. So we're not as good at it as what we thought. We've talked through the pneumococcal. Hep B. Who needs Hep B? Who can have a Hep B vaccination? Huh? So would that be a free one? What if I was 27 and going to travel? There are still a category of people, you know, that are in their 20s that didn't, the more serological testing, the more non-converters we find. So if you've got somebody going for travel doing the serology is a good thing. Who else? Who is it recommended for? Yeah? Anybody read the chapter in the book online? Because in New South Wales in 2011, Hep B became free to all those people that it's recommended in the book. So that's all household contacts of people with Hep C, Hep B or HIV, people with liver disease, people with renal disease, people with pulmonary diseases, people nearing dialysis. People with Hep C need to be vaccinated for Hep B. There are so many people that need Hep B vaccination, and it's one of the cheapest, and that's free to all those people in the book. And so I do a lot of Hep B vaccinations. People are more happy to take that than what, in the mental illness, they've got a paranoia around the flu vaccination. So don't forget Hep B. What about DTPA? We know, don't we, Boostrix, it's lasting less than 2 years, the immune response. Less than 2 years. So maybe instead of doing an ADT, we need to do the DPTA. It's only $35. I know that's a lot of money, but it's not like $100, yeah? MMR, we're hearing more and more about measles, aren't we? Anybody born after 1966 can have 2 MMRs for free. Anyone, doesn't matter what their age is. And I don't know about other states. I thought it was across Australia, but where it's free to catch up anybody up to the age of 20. It's free. So there's a lot of people we can be vaccinating. We need to think further than what we currently do. And Zoster, who's using it? Who's scared of it? Bloody hell. Some poor bugger died. He died. He was immunocompromised and given the vaccine and he died. It is scary. The GP has to authorise it. Even if you're a nurse immuniser, the GP has to authorise it. And if they haven't written it in the notes, don't give it. You do not want to be held responsible. What medications put somebody in the category of immunocompromised? Steroids? Chemotherapy? Antivirals? Huh? Someone said something else. Yes, yep, the spleens, don't forget the spleens. The person with asplenia or non-functioning spleen. Anyone else? Yeah, the anti-rejection. What about rheumatoid arthritis? They're all on disease modifiers, yep. So there's a lot of people we need to be careful of. How do we include medical guidelines? This is all a part of our care planning. We need to think about the vision. We need to think about the sensation, the circulation in the peripheries. How is the cognition going here? Because what's the biggest cause of dementia in Australia? You better come and have a care plan. We get you sorted out. Oh dear, that's the perfect answer. It's vascular dementia. Cardiovascular disease is the biggest disease in Australia and it causes everything else. Yeah? So cognition, we need to have a good long hard look at it and we need to talk to people about it. Ventilation, how are the lungs going here? Cardiovascular assessment, you've got to look at it all, don't you? We need to know what the cholesterol is. What's this ratio? What's going on here? What is the HbA1c? Or what is the blood glucose or fasting glucose? Where are the triglycerides in all of this? If the triglycerides are elevated, what's going to happen? Where's it all going? Well, what's the cause of it to start with? We might have all done it to ourselves last night. So alcohol is one of the causes of elevated triglycerides. And the second one is eating more carbohydrate than what's required. Because remember, the process is to store the glucose as fat, yeah? And it's going to be a fatty liver, and a fatty liver leads to cirrhosis. Cirrhosis leads to liver cancer. So we need to address the triglycerides, and if the liver functions are already starting to be looking like they're out, then maybe we do have a fatty liver on the way here now. We need to get in there and get the ultrasound, see what level we have here, so that we can help this person understand what's happening and help them rearrange what they're doing with their nutrition. And all that stuff that we did in the beginning. And it's there again because I remember it when I get to this stage, I put it all into the context. So what was the blood pressure? Is it in line with all the other things? Was that blood glucose? How was the BMI? Is it all working together, and is it with the guidelines? ECGs. Who reads ECGs? Yeah, there's a few of us, so it's really good. But, you know, who knows what a normal ECG looks like? Well, why didn't you say that you're reading ECGs? Because that's a key. If you're looking, you're learning and you're understanding. And just to look at every one of those ECGs and say, yes, we've got one here. And each time you look, one time you'll go, there's something funny about this one. Yeah? But if you don't look, then you're never going to learn. Are they on a statin? Because, of course, if their triglycerides are up, then we're going to have to put them on Lipidil as well, aren't we? We're going to be looking at multi-levels here, and we might have a combined statin. Are they on an antiplatelet? Are they on, or do they need mini aspirin or clopidogrel? And what's ED? So erectile dysfunction. The penis is a barometer of the heart. And we know that. So if the old fella's not working, then the tick is not working. Yeah? So we need to ask this conversation. We need to have it. How's it all going for you? Because we're going to have to do further investigation. And in that 45-year-old health assessment, I love it. How's it going there, boy? You know? Let's get up here and have a look at this old ticker, because I think we got something going on here. And that's researched, evidence-based. So erectile dysfunction will tell you that there is cardiovascular disease. So it's a good one to get people in with. Renal protection. Yes, where's the EGFR? How much water is it that they're having? Do they have microalbuminuria? What is the albumin-creatinine ratio? Are we starting to push up? Is it in normal limits, but the EGFR's heading down, the albumin's starting to head up? Are they only drinking 500 mils of water? Can we turn this around yet before permanent damage? Is the BP at target for their EGFR? What is their EUCs? What's their potassium? Because with all the medication, we can be really changing and the potassium can be elevating. What about the sodium? All the psychotropic medications can alter sodium levels. Now, we've got all these horrible the extra sugar, glucose out in your urine, and it's an osmotic diuresis that's taking the sodium with it, and it's getting the antidiuretic hormone working. So it's putting everything out of whack. But, it's great and wonderful. We've got this new drug. Yeah. It helps cardiovascular disease as well. Well, of course it will. If it's going to bring down the glucose, it's going to help cardiovascular. But is it worth doing all of this to somebody? Is it worth that person having to get up all night long to go to the toilet and spend all day long drinking 3 and 4 litres of water? I don't think so. Yeah? So we need to look at the consequences of what's happening. And are they on an ACE or an ARB? Fabulous. You know, what's an ACE? ACE inhibitor, how does it work? See, we pick up the words, don't we? But we lack the understanding. And in that own way, how can we help a person learn about their medication? Because an ACE inhibitor inhibits the converting enzyme, stops angiotensin 1 going to angiotensin 2. And angiotensin 2 is a powerful hypertensive agent. So it blocks it from being manufactured. And an ARB has the same outcome because it actually blocks the angiotensin 2 receptor. So angiotensin 2 can't actually bind to the receptor and be activated. The outcomes are more around the ACE than the ARB, but you'll find you'll have doctors that are using, they'll either do ACE or they'll do ARB. But interestingly, we use it for renal and stuff, don't we? But once the EGFR is really getting down around the 45, we often have to take them off the ACE or the ARB. And they certainly need a renal physician to manage this side of things, and often it's us that point that out, that the EGFR's down low enough, we need the kidney bloke in here and his opinion, yeah? And do not let a GP have a person on an ACE and an ARB without a renal physician saying that that's the right thing to do, because you're killing them. They'll come to an early death. And are they on the diuretics? We use them all the time, don't we? But are they now cooking the kidneys? Are they taking Nurofen or any other non-steroid on a regular basis? Because it's cooking the kidneys as well. But people don't know that. Nurofen you buy, you can get it at the supermarket. The little green footballs, it's Advil. You know, it costs 1 cent per tablet kind of thing. They're good for headaches, yeah? But if we don't know this, if we don't ask the questions, we're not going to get there. What about all the other tests that we have to do? The full blood count, the thyroid function test, the CRP, the B12, the folate, the calcium, the phosphorus, magnesium, vitamin D, STI screen. Like, it's exhausting sometimes, isn't it? Yeah? But we do need to understand when these investigations need to be done to keep on top of it, yeah? And make our recommendations. And it's one that I write all the time. Blood's due. That's what it is. Priority to date, blood's due. And I've gone beyond it now. I print the form now. It's just all organised, yeah? So it gets signed off and stuff like that, with agreement with the GPs and pathology, not just going out on a limb here. And we've all talked through the tests that we want on an annual basis, and 3 monthly and 6 monthly, yeah? But sometimes it's up to us to bring the STI screen into it. So when we get to the person-centred goals, we are after authenticity. It's not improve your blood glucose, and it's not walk half hour a day, and it's not drink more, improve your fluid intake. We need to take into consideration where is this person in stages of change. If they're sitting at pre-contemplation, they're not going to walk out the door in action. All we can do is hope that we move them from pre-contemplation to contemplation, get them one step further down the path, yeah? So we need to understand these frameworks so that we can use them to help guide our consults. And health coaching or motivational interviewing, anybody using that as a part of their care planning process, can be hard to squeeze it in, but this is really where we get to identify what it is that the person is going to do or not, yeah? We're looking at, what is important to you? How important is it? What's the priority? How important is it to you? What are the barriers? How confident are you? How ready are you? And that way that we get to know, so somebody might want to stop smoking, but they're nowhere near there yet. But we can say to them, you can ring the quit line, have a yarn with them. They'll have a yak and a yarn with you about quitting smoking. You don't have to have quit, and they're there until 10 o'clock at night or something. So when they're at home and they next think, oh, geez, I'm going to give up these dozens, this is no good for me, they might ring the quit line. That is such a positive step, yeah? And we know SMART goals, don't we? The SM are small. They want to lose 40, 50 kilos. We want to get them to look at agreeing with 3 kilos in 3 months. Is it much weight? They say, I want to lose 10 kilos in the first month. Are they going to achieve it? So are they going to stop? So we, work around the, if we can do 3 kilos in 3 months, are they going to achieve that? Most likely. So they're going to come back, and often they'll exceed that. And they'll come back and they'll go, wow, that was really good, and I'm going to keep at this, yeah? So we're taking away the negative of it. We're bringing them back to realistic by using small. The A is authentic. Authentic means that it is the person's goals. It's not the GPs or the nurses or the husband or the wives or anybody else's, it's the person's. It's not the clinical guideline goals either, yeah? Because if it's not authentic, then they are not going to do it. I got it now. And then the R is reevaluate. The psychologists tell us that the most important step in achieving goals is to sit down and have a think about it, yeah? So they say we should do it every day. But in practice, people will commit to doing it once a week. So once a week, spend 10 minutes, just 10 minutes sitting there thinking, how did you go with your goals today or this week? What barriers did I encounter? And how am I going to overcome those barriers next week? Isn't that clever? Just think for the person to reflect and come up with their own ways of dealing with this, yeah? So the re-evaluation is really important and the time frame stays there. So let's get rid of the specific, measurable, all that kind of disengaging crap, and let's bring in something that might work for a person, because in the end it is people that we are here with, yeah? It's not scientific stuff, it's not anything else, it's a person sitting there entrusting their health in your hands. This is a beautiful Lake Illawarra. I love this picture, but mind you, on the new one I took it out because the collaboration doesn't look right there, and there was a much better picture. Gorgeous photo. That one we had before was over to the left of this in the earlier part of the day. You get here? Who prints the referrals? Doesn't it feel like this? It can be so horrific. And look at all these people that we might be taking into consideration. Who puts the optometrist on their team care arrangement? Yeah? It's really, really important. Everybody needs to go and have their eyes checked. Everybody. Is an optometrist an ongoing provider? Because they're going to see them every year or every 2 years. Because if you send somebody to a one-off appointment with a dietitian, they're not a team care arrangement, they're not qualified, because it's not ongoing. So if you send them to 5 different people in the year on those referrals, none of them qualify because it's not ongoing. But if they're going to the CDE once a year, every year, that qualifies. But if you're doing a care plan saying go to the dietitian, so it's better to do the care plan and give them 3 to the dietitian. It's going to help them more as well. Sometimes it's hard to work with the GPs around this because the GPs feel that they're their referrals and they want the person to go to whoever they want. But if the person doesn't want to, guess what? They're not going to. And that now makes the team care arrangement invalid. So it can't be billed or reviewed again. So the idea is to connect the person with who it is that they want to be connected with, yeah? Because that's who they feel is going to help them. And encouraging our GPs to understand that is really important. Yep. No. So an optometrist is not even on that referral page. Community nurses aren't either, and if they go to, say, the diabetes team at Community Health, where there'll be a dietitian, exercise physiologist, CDE, they don't need any of the appointments for that. So it's only those that are on that page and in private practice. So it makes it a little bit easier to work out who to give them, who to work it out with, yeah? And it's every calendar year, remember? So the folder, I love putting the care plan in the folder. It's engaging to hand it over to the person at the end of the consult. It's all signed off, all their pathology tests are there, all their medications, the whole thing that we've talked about, everything is there, and it's just wonderful. And then they bring it back. When they go and see the specialist, I put those little tabs got their ECG and their recent pathology and they're going to see the cardiologist, and I go tab, 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 make sure you show them those pages, yeah? And it's so empowering for these people to have that in their hands and bring it back to you, yeah? It's really important. Great way of communicating. Always thank the person for coming, always. And congratulate them on stepping up to the plate now and becoming a member of their healthcare team. Invite them to call if they have any questions or come back and see me. And I love it when the phone goes the next day and I get this message and it says, Mr. Brown from yesterday said you've got spelling mistakes. So can you ring him and we can fix them? And it's like, I love Mr. Brown. I'll go home and fix them on my way home with him. Like, he's read the care plan and he's picked up spelling mistakes. How that is just so satisfying that I've engaged him with his care, yeah? For him to do that. And I always arrange the follow-up before they leave, yeah? We'll see you in a month, we'll see you in 2 weeks. Some people I see every week because remember it's people with mental illness. So some people I actually see every week and I ring them 2 days afterwards. And that's the way that we have to do to keep them safe. Forward planning, look at all of this stuff that we've got to get done in the next 12 months. There's so much. And sometimes you can spread your 9/7s out and say, right, I'm going to use one to do a specific heart check. I'm going to use one where we're going to talk about protecting the kidneys. I'm going to do one for vaccination and I'm going to do 2 for motivation. And you can, book them every couple of months. You can work out a schedule because if you've gone to the trouble of doing the care plan, you need to be the person that goes to the trouble of doing the review. Why would you go through and engage with this person and never see them again? Because if they come back for their review and they expect you and they don't get you, then they're not going to be very happy either, yeah? That's what provides comprehensive person-centred care. We talked about this at the beginning and you can see the picture says it all. How happy is this patient? He's so grateful. And look, he's clasping the GP's hand. The GP's grinning. His teeth are showing. He's patting him on the shoulder. Everybody is just so happy here. And look here in the background. Look, she is so proud of the hour that she has just spent and she's got the folder ready to give him. This says it all. Work hard to get the GP to come into your room and have this 3-way team communication. This is evidence of valuable care that patients really rise to and appreciate. Work hard. But on that process, you've got to give some kind of handover to the GP. Even if it's written down or whatever it is, but you've got to do somehow bring their attention to the priorities of the day. Yep. Thank you very much. That was my collaboration picture. See, going down that pathway of connection.
I'd just like to, on behalf of everyone, to thank Ros for doing such a great job. And I guess the take-home messages that I've actually personally got was it's a collaborative team approach, person-centred, and nurses need to continue to strut their stuff. Yes.